you may, if you're on the Zoom side, the virtual side, have noted that this meeting is being recorded. So I hope that you're on board with that. The goal is that other people will be able to, who weren't able to make it today or are not able to come for the whole thing, are able to access it later. If you have registered for this presentation, even if you don't attend, you'll be sent a link to the recording later on. Questions during the presentations, please feel free to pop them into the Q&A, not the chat, the Q&A, and we'll sort of address and go through questions from the room and from the virtual room at the end of each session. We'll begin with a kickoff, some opening remarks from Lorraine Blackburn, who has a long title, and I'm hoping I'm going to get this right, Vice President of Professional Practice, Chief Nursing and Allied Health Officer, and Chief Clinical Information Officer. Following that, Hannah Rosenberg, CNS for Critical Care here at VCH, will come up briefly as well.
Thank you so much. I'm absolutely thrilled to be here today at this inaugural event. And I just want to start by saying that every day nurses across this organization are leading change, driving innovation, and advancing practice. And that is impacting the quality and learning practice environments that our clinicians work within, and ultimately impacting the outcomes for our populations that we serve. And so I think it's really important that we celebrate that we come together, that we learn from each other, and that we just have an opportunity to build the community amongst, as what was said, the awesomeness that lives within all the nurses within Vancouver Coastal Health. So I'm just thrilled to be here today. I want to thank you all for spending time with us today, whether you're here in the room or online. And I hope that we can continue to do these sessions and bring your ideas forward for what you know is going on in your areas across the organization. I know there's lots of good information that are in the presentations today, so I'm not going to take any more time, but I will turn it over to our next speaker. I unfortunately can't spend the whole time, but we'll be here for part of it today. And again, just want to honor our presenters today and thank you for being here.
Thank you. Before diving into today's presentations, I'll take the quick opportunity to briefly introduce the group of nurses who are responsible for putting on today's event, the Vancouver Coastal Clinical Nurse Specialist. For those of you who don't know, a clinical nurse specialist, also known as a CNS, is an advanced practice nurse with a master's or doctorate in nursing and a deep clinical experience in a specialized area of expertise. At Vancouver Coastal Health, we're fortunate to have CNSs working across the organization in a wide range of clinical areas, including, but not limited to, emergency, vascular access, dialysis, professional practice, and so much more. One thing I've learned as a CNS is that no two of us have the same job. Our roles are as diverse as the challenges we face in healthcare. But our shared goal is to improve patient care, support staff, enhance systems, translate research into practice, and lead initiatives that drive excellence in healthcare. Here are just a few examples of the incredible work our CNSs are doing across Vancouver Coastal Health. Tom Yang from the Vascular Access Program and Medical Infusion Clinic is leading a health authority-wide implementation of alcohol-impregnated disinfecting caps for vascular access lines to reduce infection rates. Carmela Redhead at the Epilepsy Clinic is revolutionizing how patients are triaged for the inpatient seizure investigation unit. Julie Lockington in palliative care is evaluating the impact of embedding a specialty nurse in the emergency department, a project that could transform patient and staff experiences while improving departmental flow. And Pauline Shapton at the Breast Reconstruction Program is designing an interactive website to help breast cancer patients navigate their reconstruction journey with evidence-based resources. This is just a glimpse into the expertise and innovation that CNSs bring to healthcare every day. I hope it inspires you, and whether you're collaborating with a CNS or interested in becoming one, yourself. So thank you all for joining us today to celebrate nursing excellence across our health authority. We all hope you enjoyed today's presentation.
Right, so our first topic and speaker, Christina Hagner, is going to talk to us about the Vancouver Coastal Health Regional Wound Care Strategy, a framework for quality improvement. Christina Hagner is the Regional Clinical Nurse Specialist in Wound Ostomy Continence and works with all of the nurses specialized in wound ostomy continence across the health authority in acute, community, long-term care areas from Richmond to Bella Coola. She started her nursing career as an LPN in cardiac surgery and rapidly fell in love with wound care after caring for patients with dehisced sternums. Her passion for prevention of surgical site infections led her into her master's degree, where she focused on challenges in preventing SSIs. It's no surprise that she'll be talking to us today about preventable wounds because it is her favorite topic. Please give a warm welcome to Christina.
Okay. Hi, everybody. I'm very excited to have everybody here for our inaugural nursing grand rounds. It's a really important topic that's very close to my heart in terms of supporting nursing excellence. And this particular topic is very close to my heart because I love wounds. I love preventing them. I love treating them when they happen. And I'll try not to get too overboard with that. So today I want to talk to you about what my team and I are doing in terms of preventing our complex wounds that we see across the health authority. Before we talk about that, though, I wanted to center us in the conversation around what it means to be a person in our care with a wound. Every person who presents to you with a wound has a story. There's a unique series of events that has brought them into your care. And what I wanted to do was highlight two cases. These patients have kindly given their permission for their stories and their photos to be shared. And I'm going to preface the first picture by saying, again, I'm a wound care nurse. We're talking about wound care. I am going to show you a picture of a wound, but I tried to pick a tasteful one that's not too overwhelming. I'm going to share a story about our first person we put into total contact cast. So this is a photo of a diabetic foot ulcer. This person had been coming into one of our community clinics for over 15 months, having either twice weekly dressing changes or sometimes daily dressing changes. What we did with him, he was our first patient that we put into this thing called total contact casting. It's a cast that offloads pressure, and it allows the wound to heal, which we did. But this is not the important part of his story in particular. 2 days after we put the cast on, he came into the clinic and he told us for the first time in 2 years, he had no pain in his foot. So we were able to manage his chronic pain by using a technology and a therapy. And that for him was the single most important thing. So it wasn't just that we had treated his wound and eventually we were able to heal his wound, which is very important. But for him in particular, we managed his chronic pain. The next thing that I wanted to talk about was this little cutie here. This baby does not have a wound, so don't be alarmed, but the baby's mother did. She underwent an emergency C-section for preeclampsia, and she had a bleed intra. On post-op day 4, she felt a suture pop, and because she was a nurse, she knew exactly what that meant. Proceeding to excision, debridement, and healing now by secondary intent. She had a surgical site infection. Now, importantly for this patient, her baby was born 2 weeks before COVID shut our world down. And that's important for a couple of reasons. We're going to see on the next slide when we look at the impact of wounds across our organization and kind of talk about that a little bit. But enough about me and my baby. We're going to talk about everybody else across Vancouver Coastal and what we're experiencing with wound care. The number of patients with wounds cared for across our organization is on the rise. This is data from our community settings, and what it's showing is that wound care is accounting for approximately half of all of our nursing visits in the community space. Even accounting for a 10% population increase over the last 5 years, the numbers are still rapidly increasing. We've observed an increase in approximately 37,000 nursing assessments annually that are directly related to wound care, again, in the community space. If you do some fun math on that, that's about 11 FTEs worth of nursing assessment time for wound care. Additionally, there's an increase of 3,000 wounds per year, while the heal rate of wounds has significantly decreased. So this means we're seeing more wounds, they're taking longer to heal, we're healing less of them, and we're creating an increased demand on our system to care for these wounds. Particularly notable is our sharp increase in wound assessments and number of wounds in 2021, as well as the decline in heal rate, and that's captured in the graph in gray. This is believed to be a result of COVID, where resources were allocated away from direct patient care, and these patients had less access to specialty care nursing. So remembering our folks from the previous slide, they were both impacted by the shifting resource that COVID placed on our system. Interestingly, while this data is community data, we do have preliminary data from Cerner that supports the increase in assessments and increase in wounds as well. So in looking at the type of wounds that we care for, we encountered 3 preventable wound types that account for 1/3 of all of our wounds that we care for. These are diabetic foot ulcers, they're pressure injuries, and they're surgical site complications. Each wound type has preventative care interventions and specific areas where we've improved the quality and consistency of care that we provide. And importantly, of that 11 additional FTE that we just talked about, 3.5 FTE is dedicated to wound assessment for these particular wounds. So quite a lot of extra work on the plate. Some fun facts, because people love fun facts about wounds. Diabetic foot ulcers carry a higher mortality rate than certain types of cancer, and they also account for over 100 amputations across our health authority per year. Pressure injuries are our single most common wound type that we see across acute, community, and long-term care settings. And our surgical site complications, which range from infections to dehiscence, readmissions, reoperations, these are maybe the most preventable, but they have the highest upfront cost. We developed a wound care strategy to address these commonly preventable wounds, and since June of last year, we have 12 demonstration sites across the health authority that are implementing change. They're focusing on prevention through interventions, education, and evidence-informed care. So this, I wonder if I can, do you know how to take the OK off the slide? Is there a magic way to do that? Sorry. Got it. Nice. Okay. So this is the framework of the wound care strategy, and I wanted to spend a bit of time going over how it is impacting the work happening across our sites. Our vision is standardized wound care. We're hoping to prevent wounds. The structure of the framework represents a building which supports our patients at the top. They're at the foremost front and center of the care that we give, and they're also the reason why we're here. I appreciate not everyone is keen on nursing theory and thematic representation and framework, so I'm not going to talk about that part. But I just want you to know that this beautiful framework has been 5 years in the making. There's been lots of reiterations, conversations, and lots of data to support the reason why it looks like it does. I will highlight that we have 4 sections to the framework. We've affectionately coined them the 4 Ps. So we have our people, process, pillars, and principles, and we're going to focus in on the people in the process. So a key success to any implementation is engaging the right people at the right time with the right information to pique their interest, or as is often the case with wounds, sometimes they're distant. The people of our framework support engagement and implementation of care to give better outcomes to our patients and families. This work is undertaken by our frontline care teams, and this includes everyone from housekeeping up to physicians. It's supported by the site leadership, where we've engaged through collaborating with our allied partners, our mentors, our educators, our managers, professional practice, quality. You get the idea. We engage everybody. The strategy is supported by our steering committee, who we regularly report to. And again, they're made up of a patient partner. We have operations, we have practice and quality on our steering committee, and data analytics, importantly, who guide and support our implementation and step in to address barriers as needed, and then help us support scope and scale. The process section of the framework is where the action happens. It's where the change begins and where it's sustained. Our VCH values are embedded in the roof of our framework. They keep us safe and protected, not only in the work that we do, but also for the people that we care for. The protocol used when establishing a site participating in the strategy has 5 steps. And if anybody's ever done any quality improvement, anything, you'll recognize the steps. Change, big or small, requires a champion at the site to shoulder the burden of the change until frontline staff are able to see it. An environmental survey is critical in terms of learning the culture of the site, as well as who the key players are, both for and against, in order to collaborate and acknowledge what opportunities are going to be relevant to their particular site. Not all sites are the same. What works here in ICU is not going to work in long-term care, right? But there's something that will always fit, no matter what the culture is. Something always fits. And once you have it fitted into place, you can start to measure change and share it back to the sites in order to encourage them to continue to sustain it. The process is sustained by an organic shift in foundational nursing practice. And this is by far my most favorite sentence associated with this work, so I'm going to repeat it again. The process of preventing wounds is sustained by an organic shift in foundational nursing practice. And you can absolutely argue that frontline practice might be a better term because we are associating all of our practice with frontline staff, not just nurses, but we're at nursing groundhouse today. So here we are. We've seen change in sites where we haven't implemented anything simply because there's buzz going on about the work. So let's talk a little bit about the work that we're happening. And I'm going to try and talk a little bit fast because I know we're a bit crunchy on time. So the way we've set up the next few slides is very similar. We're going to talk about the impact of the wound's current state. We're going to talk a little bit about what we've put in place in terms of interventions and prevention. And then we're going to share some key successes that we've seen in the 6 months that we have been live with our strategy. So last year, approximately 370 patients with 608 diabetic foot ulcers were treated in our community space. There was a 30% heal rate, and it required about 162 days on average to heal. So for the 30% that healed, 162 days. They required over 13,000 nursing assessments and incurred over $234,000 in product costs to treat. And note that this cost does not include our nursing time. It doesn't include readmission, reoperation. It is simply the dressings put on wounds. Our demonstration sites across Vancouver and Richmond have implemented standardized care plans to determine the appropriateness for the novel casting technology we learned about in our first slide. Total contact casting greatly improves the average heal time and rate. The assessment for TCC is done by an NSWAC in collaboration with our interdisciplinary team. And they screen patients for appropriateness and then follow them through the therapy to make sure that it is the ideal thing we should be doing. Additionally, we've implemented peer-led education sessions, which provide easily digestible information from a peer, not healthcare provider. And if anybody has seen our posters floating around, or if anybody is interested to share this information with your people who have diabetes, please connect with me after, because we have a session happening next Friday. So impacts to the patient are pretty immediate. They experience faster healing, there's reduction in infections, and a lower risk of amputations and death. And importantly, staff in our demonstration sites have reported increased morale and retention related to actually seeing these ulcers heal. So if any of you work in a community setting, or if any of the folks online, I know I've seen a couple that I know work in community settings, imagine being able to heal somebody who's been coming into your clinic for 243 visits. So across the system, we see reduction in nursing assessments, hospital admissions, and prevention of operations by rapidly healing these wounds. In terms of planetary health, we've seen reduction in total product mass in the landfills, as well as reduced CO2 emissions related to our transportation to and from care settings. An important initial success of this work, again, is the experience of our first patient. So we talked briefly about his perspective of having his pain managed. From our healthcare perspective, we had this fellow in our care for 243 visits, you can see on the slide. In 13 visits, we were able to heal his wound. It's a very significant impact to be able to manage this person's long-term chronic wound. And I can also share that the rates of diabetic foot ulcer healing using total contact cast is approaching 80% in our demonstration sites as compared to our 30% that we saw previously. Specific to this patient, and in terms of trying to align with our planetary health pillars, we looked into some planetary health metrics. This patient in particular reduced product waste in the landfill by 2/3, and he also saved over 1,100 kilograms of CO2 emissions related to transportation, not having to come to and from place. Moving on to pressure injuries, last year they accounted for more than half of these 3 wound types combined. We spent a lot of time on our pressure injuries. We heal less than half of them, and the overall average time to heal is 157 days. And noting importantly that the lower stage pressure injuries that don't break the skin heal much faster than our deeper ones involving muscle and bone. We've developed standardized care strategies focusing on prevention and healing, including education and risk assessment to reduce our incidence of pressure injuries across our sites. Standardized care plans utilize the grading risk assessment tool, and if anybody in this room does not know what this tool is, please talk to me after the presentation. It's very important. And it's a tool that helps predict somebody's risk of pressure injury, but also gives you care plans to put into place to try and prevent pressure injury from happening. So what we've done is we've provided unit-specific education sessions, and we're implementing bundles of prevention interventions across all of our sites. Some of these bundles include things like reducing our linen layers. We're saying goodbye to green Soco pads, going briefless, and using some pressure injury prevention dressings on our at-risk folks. And we have 6 demonstration sites across the health authority that are listed here. Impacts for the patients with pressure injury include reduction in infections, multiple surgeries, and death. And importantly, as the most common wound cared for across our organization, prevention of pressure injuries will increase nursing capacity by decreasing the nursing workload associated and currently undertaken. System impacts include increased capacity for patient flow, decreased days in care, and reduced admissions and operations. I wanted to take a moment to highlight the exceptional efforts done at Squamish General Hospital. They're one of our pilot sites. It's a small bed community hospital. There's 16 beds in this hospital, and the team is making some really big changes that they're able to actually sustain that we've seen in 6 months. The graph you see here, I'll walk us through because it might be a little convoluted. What we're looking at is the impact of prevention in action. So we're showing the prevalence of healthcare-acquired pressure injuries by stage across 3 time points. Baseline was before we put any interventions in place, and it's shown in orange on the graph. 3 months and 6 months are 2 time points where we did prevalence studies. We actually physically went to the patients, turned them over, and checked for pressure injuries. And that's shown by teal and purple, respectively. So what's important about this, or what's important to see, is that while we had similar numbers of pressure injuries at 3 months and 6 months, which I anticipated seeing, we saw only stage 1 pressure injuries at the 6-month mark, which is our, kind of entry stage for a pressure injury. And nothing was higher than the stage 1. You'll see on the graph, there's 2 that are stage 2, but those were present on admission. They can remove them. So very important. And I just wanted to highlight that results of pressure injury prevention, they don't magically happen overnight. We don't put changes in and expect to see, no pressure injuries by the next day. But this result actually exceeded my expectations compared to some of the other sites where we're still trying to get folks to do grading assessments. They at SGH are doing exceptional work. So I wanted to highlight that. Moving on to surgical site complications. So last year we managed care for over 800 patients with over 1,100 incisions that were healing by secondary intent. So they were either infections or head-to-hist oracles. On average, they took about 73 days to heal, and they required over 13,000 nursing assessments and over $200,000 in product cost. We're focusing on known high-risk patients from vascular surgery and obstetrics, and what we're using is a specialized dressing that stays on longer. It creates an airtight seal and removes harmful fluids and holds our wound edges closed. So for folks who are aware of these types of dressings, it's incisional negative pressure. And essentially, it's a dressing that goes on in the OR. It stays in place for 5 to 7 days, and it really lowers the chance of the wound dehiscing or becoming infected. To support implementation, we created standardized incision care plans and discharge instructions for our patients, and we embedded that within Cerner. And we know that by involving patients into their care journey, it actually helps promote better care of incisions, which we've seen in hospitals across the country. So patients will have fewer infections, better incision healing, including less pain and scarring. Our nurses will spend less time on wound care, which is what we've been talking about. And with shorter hospital stays and fewer readmission and reoperations, we're going to have more people being able to come in and receive care. I wanted to show our initial data from our vascular site here at VGH. Their baseline rate of complications was about 17%. And after 4 months of using this incision dressing, they're down to 11%. So what have I learned in this work? Most importantly, supportive leadership is critical to the success of a project, big or small. The wound care strategy would just be a great idea if it wasn't for alarms and bells. Maybe it'll go maybe one. That's fine. Pardon us while we get a code page. Excellent. Good. So yes, if we don't have the support of our directors and our senior leadership, and in my case, that's Jay, who's my director here. Yes, well done, Jay. Also, Lorraine and Heather Mack have been very helpful in Tony's idea.
Hi, Acute, Code White, Jim Patterson Pavilion, second floor, Burns Trauma High Acuity. Code White, Jim Patterson Pavilion, second floor, Burns Trauma High Acuity.
Of course, it would be Burns in my talk. We've also learned sites are not always ready for us. There's been a bit of a palpable change to the essence of nursing post-COVID, and that's part of it. And part of it is just competing priorities on site. And so sometimes your grand idea might not be front and center. And so it takes a bit of flexibility to be able to work with sites to figure out what's going to work best for them. And the last thing I learned very quickly is that while change is often slow, it's actually probably a good idea to have it be slow so that you can then see that sustainment over time. With that, I'll close out with a few pictures from some of our demonstration sites, and if we have time for questions.
Amazing, thank you. Such cool data. I really love data so much. Do we have any questions either from the online world or the in-person world at all? Could you turn on your mic? It's to your right. Thank you.
The green soaker pads, it's coming to a unit near you, my friend. That's a two-part question. One, we have a DST around bed linens that our interdisciplinary regional group is drafting and hoping to go out. But all of our pilot sites for pressure injury have gotten rid of them already.
Anyone else? I have a question. Oh, unless there's somebody, is there somebody out there? Yes, Alana.
Christina, very good to be here. I was wondering if you could give us just a brief, a bit more explanation about the increase in wounds overall. I'm wondering whether or not there's any fact of like additional reporting or like is there a bigger data element to this, or is this reflective of current process or both?
It's a good question. I'd love to do a deep dive to figure out exactly why we're seeing more wounds. My initial thought is that because we had shifted so much resource away from wound management, especially in the community, that data is community data specifically, but we are seeing more wounds kind of across the community. I think that because we didn't heal as many, we have sort of that result where we see more wounds over time because they're taking longer to heal. I think we are starting to see a little bit of an upward trend in heal rates now that we're few years out of COVID. I'm hoping that improves, and I'm hoping we can get back to sort of our 2018 rates. That's kind of what we're hoping to do with some of this work. But the short answer is I don't have a good answer as to why. I just have a theory.
Part of it is we're taking care of sicker people who are unwell, who don't feel very well, and we see that a lot. And surgeries are happening on sicker people, and again, feeling very well. We have almost a new category of drug use. So a lot of fentanyl and has places, and then new fingers in the hospital. That's a lot of that. And that's newly after adopted to the council. Over 100 people in their
That's great. Awesome.
So to paraphrase for those who may not be able to hear in the virtual world, just a discussion around like why the rates changed so abruptly with COVID. Erin, who is one of our wound ostomy continence nurses here, if I'm not mistaken, I think the general is just saying, also the population has changed, sicker, more complex, more acute, which is no surprise for those of us who are sort of seeing it anecdotally firsthand. Great. I think we'll wrap up. Thank you so much. Oh, yeah, absolutely. People are wondering when we will see the TCC in inpatient units.
This is a great question. Currently, it's only happening in our community spaces. That was because we knew we were putting it in as part of a strategy to sort of explore what we need to know in order to expand it out to other sites. There are some acute care sites that are doing it, hit or miss. So more conversations to come about it, but not that I don't know if we'll see it directly in inpatient units, but certainly within our ambulatory cares and some of our hospitals up the coast that have ambulatory embedded in the hospital, we might see it there.
Certainly, though, I expect if you're looking to be like a wound care champion at your site or area of practice, that you could reach out, and that would be, we're always looking for people who want to adopt and push forward change.
And our email is on this slide if anybody would like to send us anything.
We can take one more last very quick question.
Hi, thank you. It's super quick. Contact casting, is that a custom device per patient, or is that
It's
paraphrase just for people in the virtual world?
Yes, yeah. So for our virtual folks, the question was, is Total Contact cast a custom dressing per patient? And it is. The picture you see in the middle is actually me getting casted while we were doing our education for our sites that we're launching. So it's a cast. It's a cast like any other cast. It has some nuances in terms of protecting the wound, but it is a irremovable fiberglass cast that goes on, not fiberglass, ignore that. Because if it's fiberglass, we have to talk about ventilation things. It's not fiberglass, it's something else. But basically it's a cast like a cast for a bone, just not done in the same way.
Thank you so much for coming. All right, and we will move briskly along here to our next presenter from our Vancouver General. So we go from sort of a regional project down to a unit and care space project. So this one is called Bed, Bath, and Beyond. I love the title. From the VGH Acute Medicine Unit TBQI team. And so our presenter is Nicole Foster. She's worked some wooing from the room. Nicole has worked as a registered nurse for 2 years on the Acute Medicine Unit at Vancouver General Hospital. And over the past year, she's had the opportunity to serve as the team-based quality improvement lead on acute medicine. TBQI is a collaborative strategy that empowers healthcare staff, patients, and families to lead and implement quality improvement initiatives on the unit. She's found this role to be a rewarding expansion of her nursing practice and is grateful for the experience. Nicole, take it away.
Okay, hello everybody. So I'm Nicole. I'm going to be presenting to you today about Bed Bath and Beyond. So first, we'll mention what is TBQI. Like it was mentioned, it's a team-based quality improvement strategy. It's really based on collaboration, and we're aiming to continuously improving ways how we can provide high quality care to services, high quality care and services to patients, Based on collaboration, TBQI implements creative strategies to address problems within the healthcare delivery spectrum. And when I mention healthcare delivery spectrum, I specifically mean on our unit on acute medicine. But TBQI really empowers healthcare personnel, patients, and families to have an opportunity to make a positive impact on care that they're receiving within their unit. So some fun initiatives that have taken place on our unit include a comfort cart. We've redesigned our assignment whiteboards. We are going to have a Code Blue Education Day, and then we'll, of course, talk about Bed Bath & Beyond. So unfortunately, I cannot take the credit for Bed Bath & Beyond. That was created by Dr. McCormick. It was very clever. So why we started this project was, unfortunately, we received some feedback from several patients that personal care and hygiene that they were receiving on acute medicine wasn't satisfactory or wasn't being completed routinely. So due to this, we went through a few ways to collect data. We interviewed patients and we completed some chart reviews to really understand what was the problem, what was the severity, and how this was impacting patients. So through these data analysis methods, we identified key contributing factors that we found to be barriers for nurses, healthcare staff, for why personal care and hygiene wasn't being performed routinely on our unit. So as a group, we came up with some creative strategies to target our barriers that we identified. We implemented these strategies as a team, and we made sure that we got patients and families' input because it was really important to gain the lived experience of the patients on our unit. And then we'll show the impact our initiative had on our documentation. So we actually showed a positive change of 29% in documentation of personal care and hygiene on our unit, and we'll get into that. So why is personal hygiene important in patient care? So it's really important because it provides and enhances the emotional well-being of our patients. It allows them to have dignity while being in hospital, and it allows them to be felt like they're cared for by staff. It also reduces the prevalence of hospital-acquired infections. It improves job satisfaction of healthcare workers because you really feel that you're providing holistic, well-rounded care to our patients. It ensures that we're delivering person-centered care, and it gives us an opportunity to build rapport and trust with our patients during this time. So now we'll go into our data analysis. So first, how we completed this is that we did a chart review and we looked through the patient's charts and we included the day shift and a night shift. So we looked at a 24-hour period and was personal care being offered and documented. So by the rates that you see, it was not being offered very regularly. Only 46% of our patients had care documented once in a 24-hour period. And then something else that we looked at was, did patients have personal care supplies at the bedside? This was important to look at because if personal care supplies were readily available and accessible to our patients, hopefully that would reduce barriers for personal care to be performed and would be more readily available for our patients for it to happen. So this was a little bit more of a promising statistic. About 77% of our patients had care supplies at the bedside. And when I talk about personal care supplies, we're talking about toothbrush, toothpaste, comb, to do their hair, things like that. So the next thing we did was we conducted patient interviews. And we conducted interviews with healthcare staff that we thought were a very important role for why personal care and hygiene may not be offered as frequently. So 46% of our patients said they were satisfied with the personal care that they received in hospital. 100% of patients said that personal care was important for them to be receiving while they were in hospital. And then about 69% of our patients said that they were comfortable approaching staff to ask for assistance to get help with performing personal care. So, and then For our patients, we included everybody on the unit. So we interviewed independent patients, patients that needed one person assist, and then patients that also needed 2 people to assist. So everyone was included in this patient population. So then we interviewed our nurses. We found that 50% of our nurses said that personal care was important for them to provide during their shift. 93% of our nurses said that they were offering personal care every shift. And then 71% of our nurses said they were confident in where to document this in Cerner. Going to our care aides, we wanted to know what kind of barriers or how they felt about personal care. 43% of them said they were comfortable asking for assistance, but also another 43% of them said they were comfortable asking the nurses for assistance with personal care, but frequently the nurses said that unfortunately they just didn't have the time to help them at that moment. So through this, we identified some important barriers to what might be impeding personal care to be provided frequently. And then when I'm speaking to personal care, I'm talking about the performance of bed baths. So what our key contributing factors were, we identified 4 major groups. One were the assignment acuity and workload that the nurses had to deal with. Other were lapses in communication. This occurred between nurses to nurses, nurses to PCAs, friends and families to staff, and then with our independent patients. We also faced documentation challenges. And then we also had that there were dynamics between nurses and PCAs that also need to be looked into. So going back to assignment acuity and workload, nurses stated that they really found it challenging to prioritize personal care with other higher priority orders that needed to be completed. During this time, the acuity on our unit was very high. We were calling the critical care outreach team frequently. We had other things like blood work that needed to be sent. We were administering blood. So it was really hard for the nurses to plan a time in their shift where they could provide personal care. Lapses in communication. So some major things that we found were that personal hygiene wasn't being handed over from nurse to nurse. Nurses were usually handing over more important critical things regarding the patient, such as what their hemoglobin was, as an example, or being included. So this was a little bit of a lapse in communication that we found. Additionally, we found that there were issues between communications with PCAs and nursing staff. So one major thing was the length of shifts between both of these staffs. So our night shift PCAs, they work from 11 p.m. to 7 a.m. And then our day shift nurses, they are starting at 7 a.m. So really the day shift nurses are just assuming that personal care was completed by the night PCAs. There was that lapse in time, but we weren't really able to ask the PCA, did this care happen? We were just assuming it was happening. Some other things that assumptions that were made were that there were family and friends present at bedside, and we were assuming that they were going to be helping with care since they were there. But really, nurses and staff weren't having those conversations with family if they were feeling comfortable in providing care to their loved ones. Another thing that we were missing that should have been really easy to get their care completed was our independent patients. So just because they were independent, we were assuming that they were doing their own care, but a lot of the times we didn't have those conversations with them, and they didn't know that they had these options available where they could shower, they could freshen up. So we were really missing key conversations with them. Other things were documentation challenges. On Cerner, if you've used it, personal hygiene is really hidden at the bottom. So it's not something that's easily accessible. And then with nurse and PCA dynamics, this also includes PCA to PCA dynamics. They felt that there is a lack of teamwork within the unit. So PCAs were asking nurses for help. Nurses were unfortunately saying, no, they can't help you right now. And then with our On 2 of our other units, we only had 1 PCA per each side, and 1 PCA would float. So then it was really hard to complete this care just as one. They really needed someone else to support them in completing this hygiene if the nurse wasn't available. So some of the solutions that we came up with. So we had really lovely support from our management and our leadership team. They agreed to have a trial to increase our baseline staffing from 5 PCAs to 6 PCAs during our project rollout. So what this did was it allowed us to have 2 PCAs on each unit. So we wouldn't have that float PCA anymore. So we were hoping that this made care more accessible because the other PCA could work with their partner in complete care at that time. We also were able to increase our baseline staffing. So we increased it by 3 nurses. So each unit had an extra nurse to help with the workload that nurses were voicing. Another thing that we tried to do was promote conversations with family regarding personal care. So how we did this was we created a personal hygiene whiteboard. This was going to be filled out by the admitting nurse, and it would just help facilitate conversations regarding personal care right when the patient was admitted into hospital. Another thing that the board did, we had an oral hygiene and a bed bath tracker on the bottom of the board. So when care was completed, you could just put an X on the bottom, and then this could be filled out by staff, care aides, nurses. It could be filled out by family that were helping, and we really empowered our patients to fill out these boards themselves if they were able to. So when the nurse comes into the room, they can see the tracker, and if there's a check mark checked off on that day, then we knew that care was performed. So this kind of helped with the communication aspect that we were having challenges with. And then we also included a space on our whiteboard where patients could write things that were important for them regarding their personal care or their care in general while they're in hospital. And we'll go through some examples after. So our dynamics improved between nurses and PCAs just because it improved morale and stress because we had more people available to help. So PCAs said that they had a better sense of teamwork between themselves. And then nurses also had more time to be offering care because they didn't have so many tasks that they had to finish within their shift. Additional things that we did, we had in-services, we had admission kits that we introduced. They would contain personal care supplies that we would supply to the patient while they were admitted. And then we developed a frequently asked question PDF that we would give to nursing clinicals that would come to our unit so they were aware about our personal hygiene board before they got here. So this is just one example of some of the education we did for the in-services. We just wanted to make sure that there was clarity on how to document hygiene and personal care in Cerner. So this is just an example. And then on to our personal hygiene board. So there's one that's not filled out, and then the other one is filled out with an example. We had the patient's preferred name and what they would like to be called while they're in hospital in the top corner. We listed the date from Monday to Sunday each week, and this aligned with the tracker that was on the bottom. We did dates once a week because we really wanted to not make this board more work for nursing staff to complete because nobody likes to do more work. So then underneath the date, we have a little area that's something the patient would like. So this person said that they like to brush their teeth after breakfast. I've also had people they wanted me to include like cultural practices that they wanted to have in hospital. I had a patient who was Indigenous who wanted us to keep her hair. So when she was discharged out of hospital, she was going to do some healing practices with it. And then underneath, we have the level of assistance our patients needed. We had independent all the way to two-person assist. Our lovely occupational therapists and physios really updated this for us if there are ever changes in the patient's mobility. And they left us little notes like, patient is a one-person assist, pivot to the commode. So this really helped nursing staff and care staff properly care for our patients. Underneath, we had a part that was, is family going to be involved in care? Yes or no? And then underneath was the tasks that the family felt comfortable performing. And then at the bottom is our tracker. We had a check mark, was we nurses or staff offered care and it was completed, or we had an X, that care was offered and it was declined. So this just gave more clarity to patients, family, and staff if care was being offered. But again, this also had to be documented in Cerner by the nurse. So some additional uses that our whiteboards took on that I thought were interesting to mention. We had families leave messages of gratitude, thanking us to care that we were caring for our patients. Families would leave how they were related to the patient and also contact numbers if something happened and we had to call them or we needed their assistance, maybe helping with translation or something like that. And then another fun one I thought was families were listing the Wi-Fi password on the board because we all forget it. And I think that's an important one to know. So what did these initiatives and how did these initiatives impact care on our unit? So we really saw a big increase in our documentation of personal care being offered on our unit. Our high was 85%. We're sitting right now around 75%, but we really saw a big positive change in our documentation. So some key takeaways of this, we found it really important that we needed interdisciplinary buy-in and communication between the healthcare members were crucial to implement change on our unit. We wanted to make sure that the patients and families' experiences were heard, and this was important for us to understand what they were going through, for us to really provide interventions that were meaningful to the patients and their families. And then we made sure that we were getting feedback from staff throughout this process because the change that we were hoping to make, we wanted to make sure it was realistic for our unit. And then how does this align with Vancouver Coastal's health strategic priorities and pillars? These are just some of the examples. One we can go over really quickly is exceptional care. We improved the quality of personal care and hygiene with amongst our patients, enhancing their overall satisfaction with personal care while they're on our unit. And then inclusion, sorry, I'm going over time. Our project aimed at ensuring care provided was inclusive to all genders, with the ability of patients to put in their preferred name and pronouns on our whiteboard. And then it let staff know how they wanted to be addressed. And then in conclusion, our project aimed at improving personal hygiene care within Vancouver Coastal Health. Our goal aligned with Vancouver Coastal Health strategic priorities and pillars by focusing on person-centered care, safety, innovation, teamwork, and inclusion. That's all.
Phenomenal, thank you. I noticed a common thread across both projects was just that really supportive leadership seemed to be very instrumental, especially in getting things going off the ground. Definitely. Any questions from the room or the virtual world at all? Please feel free to post in the Q&A if you're online. Alexia.
Well, I just wanted to give a huge shout out to Nicole and the TPQI group because it was an exceptional amount of work that they undertook. Medicine is a feeder unit. There's been over 100 hires in the last year. You can imagine how much work they put into this to have those kind of results.
It wasn't just me though. Cy Lonigan was very helpful and Ben Ferguson as well. They were two people that couldn't be here today, but really put a lot of work into this project as well.
Yeah, awesome work from the team. For those of you who may not have been able to hear on the web, just the outgoing manager for EMU was saying that they, for example, like high volume of hires for EMU and just sort of recognizing the significant volume of work that went into this project and getting those results.
Yeah. Oh, sorry. I My name's Greta. I was the CNS during this time, and like I just got to sit back and watch them do all the magic, and just really supported them from the periphery. They were very engaged and involved and had great insight into this knowledge translation project. And then I forced Alexia at the time to come around and do bed baths on a few occasions to actually really show the staff that the leadership also felt that this was an important initiative.
Yeah, so amazing leadership buy-in. Awesome. Alana, I feel like you made a question gesture.
Thanks so much, Nicole. I'm Alana. I'm the clinical nurse specialist for intensive care and Acute here at Vancouver General. My colleague Hannah. I just want to commend you for an outstanding presentation and outstanding project. This really highlights the foundational work of nursing, regardless of the place you're practicing or how long you've been in practice. Some of these things and the person-centeredness that you brought to this, that your team brought to this project is really impactful. And I'm hoping that you or Greta or Alexia or Julie has suggested that you submit something to Quality Forum on this.
Yes, you should submit to Quality Forum. Absolutely. We're going to take one last question from the online Q&A. As well, please note that there is a QR code on your screen for feedback, and like looking for sort of future presentations and future presenters. If you feel that you have something that would be a good fit for Nursing Grand Rounds, please email Caitlin at the email address listed here. So the question from the Q&A is asking about the increased staffing level, nursing and PCA, and whether or not there's been ability to maintain that following the project.
Yeah, due to the success of our project, we have been able to maintain our staffing levels. We're continuing to do chart reviews to make sure our documentation is staying within like an acceptable range, but we have been able to maintain our staffing levels, which has been, I think, very
amazing,
beneficial.
Yeah,
Fantastic. To add one bit of context too.
Yep, absolutely.
Just for people
more context
to their leadership. Well, like force. There was clear role definitions for the PCAs back up, so that it's not like they're just doing bed baths and not doing other work. Medicine is a very acute unit. They have a lot of modified assignments. There's other work to be done. So like proposing it's not just for one thing, but it will benefit all. Same with nursing is our baseline was never really an appropriate baseline to start with. So increasing it rationalized the amount of work that the nurses do. So there, yes, it was to help with this TBQI project, but the bigger picture is like you can rationalize it by advocating for improved overall patient care. If you were to make an argument to your manager.
Yes, absolutely. So for those advocating for more staffing, initiatives like this, certainly, but also it took into consideration the greater sort of big picture view of the unit as well. All right, thank you everyone for coming today. The first one, come to the next one.